and organization in the meeting chat, or you can email at medicaidpharmacy@utah.gov. All right, McKay, I think we've got a quorum and we've got to our starting time. So if anytime you're ready to start, go ahead.
Great, thank you very much, Brian. And thank you especially, Brian, for last meeting taking care of conducting and things like that. I wasn't able to make it, so I really appreciate on such short notice you taking care of that. So
yeah, no problem.
Perfect. So this morning, Brian already announced that we do have a quorum, and so we're able to go ahead and proceed. First thing we're going to do is we will approve or look over and approve the minutes from our September meeting. So if everybody has those, if you'd please pull them up and take a look at them. I believe they were sent late last week. Or they are posted, or they're probably not posted online yet, but just for review. And I will be abstaining from this, so if someone would like to motion, go ahead and do that.
I'll make a motion to approve.
All right, thank you, Brian. Do we have a second?
I'll second.
Great, thank you, Susan. And all in favor?
Aye.
Aye.
And any opposed? All right, and for the record, I did abstain from that, so thank you very much. The next thing we have here, Brian, do we have any other housekeeping items to go over before we jump into it?
No, just that the agenda lists Jennifer Strohacker is giving the DOR update, and that'll be new again.
You know, you kind of, maybe that's just me that you,
Noon will be giving the DOR update instead of Jennifer Strohacker.
oh, all right, go ahead.
Thank you. So last week, the DUR board has met, and I'm sorry, my voice just crackled. So last week, the DUR board met and discussed the spinal muscular atrophy. The board has approved the proposed Risdiplam and nusinersen prior authorization. The board also discussed the HER2 positive target therapy prior authorization form, and the pharmacy team is still in the process of working on that PA. The DUR board will review the newer antipsychotic agent for the month of December. The meeting will be held on December 11th of next month. Sorry, December 10th of next month. Thank you.
Very good, thank you. All right. Well, let's go ahead and move on to our review for this meeting. Where it looks like we're going over the immune globulins, and Dr. Gonzalez will be presenting to us. Dr. Gonzalez, go ahead.
Thank you. I do have slides to share with you, so let's see. Okay, let me try to get those up real quick here. Tell me when, can you see those?
Yes.
Okay. So we're here today to review the human immunoglobulins. These are concentrated antibody preparations, primarily containing immunoglobulin G, abbreviated IgG. They are considered multi-specific products since their activity is not bound to just one pathogen. While highly purified, these products can also contain low levels of other plasma-derived proteins, but these are usually unquantified in product labeling, aside from the IgG and IgA content. These agents are used as replacement therapy in immunodeficiency syndromes, or they can be used to help decrease the effects of overactive autoantibodies during immune thrombocytopenia or certain autoimmune conditions. There are IV, SC, and IM formulations available. I'll also refer to these as IVIG or SCIG or IMIG preparations. The products with the asterisk are those with preferred status on the Medicaid PDL. A couple products are approved for both intravenous and subcutaneous use, but the labeled route for administration is specific to the indication. Together, there are several indications for the IV and sub-Q immunoglobulin products as listed in blue. These are all rare diseases. Each subcutaneous product is labeled for the treatment of primary immunodeficiency. And of the sub-Q products, one has an additional indication for chronic inflammatory demyelinating polyneuropathy, and that's Hizentra right here. The two IM products down at the bottom of the table are approved only for high-risk exposures to certain viral pathogens. Immunoglobulins are also used off-label for many rare immunodeficiency or autoimmune conditions. Examples of these were listed in Appendix A of the report. Products differ by manufacturing methods from donor procurement to purification and the final excipient content. The Ig biological activity of the product is dependent on the donor population's exposure history and can be inadvertently affected during the manufacturing process. Product tolerability can be influenced by the excipient content, such as sucrose-based stabilizers or low levels of other active proteins. Ig products must demonstrate biological activity to 3 particular pathogens, including polio, measles, and diphtheria toxoid. Although products have broader activity for additional pathogens, The precise potency for others is undetermined in product labeling. The manufacturer of Asiniv is reported to use a donor population with high levels of RSV antibodies, while also meeting standards for activity to the other 3 pathogens. Yet, Asiniv does not carry an indication regarding RSV specifically, nor have head-to-head studies been conducted to determine if this formulation yields superior outcomes compared to other products. Nonetheless, this agent may be considered, especially in patients with primary immunodeficiency who experience recurrent RSV infections despite using other IG products. The frequency for IV immunoglobulin replacement dosing, for example, for the treatment of primary immunodeficiency, is typically every 3 to 4 weeks, whereas the majority of subcutaneous products are administered weekly or biweekly using an infusion pump, since the dose can take an hour or 2 to administer. To reduce the duration of infusion per sitting, subcutaneous products may be administered in smaller volumes more frequently, daily or every other day, using a rapid push infusion method. The product HyQvia has a facilitated administration, allowing for a more rapid infusion rate and a larger volume per infusion site than with other subcutaneous products. So a dosing interval of every 3 to 4 weeks can be used with HyQvia, which is comparable to the interval with the IV products and is less frequent compared to other sub-Q products. With one exception, there is no particular brand recommended over another in guidelines for these indications. The exception is Gamastan, that is specifically named as the agent for use in pre- and post-exposure prophylaxis of hepatitis A. So in primary immunodeficiency, immunoglobulins are recommended for significantly impaired antibody production. In immune thrombocytopenia, IVIG is a treatment option usually when corticosteroids are insufficient. IVIG should be offered for the long-term treatment of chronic inflammatory demyelinating polyneuropathy and is the mainstay treatment for debilitating multifocal motor neuropathy. A subcutaneous product may also be used in these inflammatory conditions for patients with vascular exhaustion or for those with intolerable systemic adverse effects with the IV products that cannot be managed by reducing the infusion rate or the dose. For prevention or modification of measles in non-immune patients, IMIG is to be used in infants and IVIG is to be used in pregnant women or severely immunocompromised patients, regardless of vaccination status. For varicella exposure in patients at high risk of severe infection, the varicella immunoglobulin Varizig is the first-line agent, followed by IVIG as a second-line option. And as I mentioned, Gamastan, the IM product, is specifically named for pre- and post-exposure prophylaxis of hepatitis A. In Kawasaki disease, high-dose IVIG is the mainstay therapy. And in CLL, IVIG or SCIG are recommended for supportive care to reduce infections in patients with very low IG levels who have recurrent serious infections. There are insufficient RCTs available to establish superiority of any one brand product over another. The choice of regimen and route for administration are based on intravenous accessibility, the IG dose required, clinical response and tolerability to trialed products, risk factors for adverse events, and personal preference or lifestyle. Administration approaches may change during the patient's disease course to meet the challenges that arise. Subcutaneous products may help alleviate some barriers to care as they may afford greater independence and flexibility with self-administration. Additionally, sub-Q products serve as an option for patients with venous access issues or for those with intolerable systemic adverse effects with the IV products, despite trying mitigation approaches. Regarding safety, mild to moderate reactions occur with 5 to 15% of administered infusions, but reactions may be lessened by reducing the infusion rate, dividing the dose, or using pre or post-treatment medications. If these approaches are insufficient, patients may be switched to a different IV product or to a sub-Q product, since sub-Q administration appears associated with less systemic side effects compared to IV administration. Severe reactions with immunoglobulins occur infrequently in about 1% of patients. All products include a black box warning for thrombosis risk and have other warnings for other rare but serious reactions that are listed there. So prior authorization criteria is currently in place for all of these IG products reviewed. The PA limits use to the product-specific approved indication, requires trial and failure of a preferred agent, or the demonstration of medical necessity. So for the PDL, you may wish to consider at least one product from the IV, IG, and SC IG classes as preferred. Access to non-preferred products can be accommodated via prior authorization for scenarios that fall outside of the labeling of preferred products, or for patients with intolerability or a conflicting comorbidity to the preferred options. Also, a clause to allow patients to continue their current product can be considered. And I'll go ahead and end with that. Also on pages 9 and 10 of the report, there's a couple tables where you can look at the indications and see what agents are approved for those specific indications, if those might be helpful. So I just wanted to point those pages out to you. And that's all I have. Thank you.
Great, thank you so much. So we'll go ahead and move on to some discussion of the information here to see, you know, what we'd like to do as far as making a plan and a recommendation. Do we have any public comment today, Brian?
Not that I know of. Before we get too far in the discussion, I wanted to sort of give everyone a baseline for where we're at. Last time we discussed this in P&T was in October 2015. And at that time, a motion was made that immune globulin should be added to the PDL with a requirement that at least one agent be preferred for each condition for which there is an FDA-approved indication for immune globulin, and that there should be one low IgA product preferred. So that's kind of where we're at with current recommendations.
Okay, thank you very much. I'm just looking over the usage here to see kind of what we're looking at.
I would propose a grandfathering clause if or when the PDL does change, because the switching from one product to another is not straightforward and is not always successful.
I think that's reasonable. Do you want to put that into a motion of how do we want to word that? Or just keep it in mind for as we keep discussing.
For a motion, typically, if we do a motion with grandfathering, we would include a look back, be 60 days, 90 days, whatever that is. So something to keep in mind. We do grandfathering.
I would allow members to remain on their current treatment with a look back for 90 days once the PDL is established as of this meeting, or if it changes from the current drug list. Brian, you might be better suited to word that.
Sure. So let me see if I've captured what you're saying. So you're considering a motion to include grandfathering for any agents within the class with a look back of 90 days. Is that correct?
Yes.
Okay.
I'll second that.
And I'm sorry, who said that they would second that? I missed that.
It's
Dr.
Chris
Valentine.
Valentine.
Oh, very good. Thank you. All in favor of that?
Aye.
Aye.
And any opposed? All right, looks like it's unanimous in the grandfather clause there. So, I mean, we need to look at, I really like the way that it was previously worded back in 2015 when it was initially put on. I'm not sure I see any indications for a need for a change despite or except for the grandfather clause, which I appreciated.
I'd agree with that. I haven't heard anything that would suggest a need for changes.
Do we need to do anything with the IM product that's specifically for hepatitis A? Or is that, because I believe before there was a one sub-Q and one IV product that were preferred. Is that correct, Brian?
Could you repeat that again?
Well, so previously the PDL said that there was one sub-Q and one IV product that were recommended as preferred. And I just wanted some opinions on whether we needed to do anything with the IM product that has the specific indication for hepatitis A, or maybe the guidelines just pointed that out, I believe.
Again, that's not currently incorporated into the recommendations that we go on from the P&T committee recommendations a few years ago, but that's certainly something we can consider.
This is Valerie. I could try to help answer that. So Brian, you mentioned that the past recommendation to require one agent as preferred for each indication, right? So Gamistan or the Gamistan, the two products are both named Gamistan. One is just prepared slightly different. Both of those have the indication for hepatitis A. So like that past recommendation would include Gamistan. I guess for hepatitis A, just that sub-Q one was recommended, but IVIG products are also recommended for other like post-exposure situations. But as the past recommendation stands, it seems to incorporate that since there really are only two IM products.
Thank you for clearing that up, Valerie.
for determining between those the subcutaneous and the IV routes in that kind of case, is there really? I don't have. I can't say I have any clinical experience with that. Where does not necessarily spelling out approval for a subcutaneous product, does that create any barriers on a clinical basis, like in terms of how it's stored or administered in clinics? I mean, I'm imagining that, a sub-Q certainly would be easier to administer perhaps in an ambulatory clinic, but I'm just speculating here. I'm wondering if anybody on the call has any input as far as whether that sub-Q formulation, teasing that out as being a something that we should consider specifically covering, whether that really provides a lot of clinical benefit.
I could try to answer some of that for you. So the sub-Q products, those can actually be self-administered. Like patients can be taught how to administer those by an infusion pump at home. So, that is kind of viewed as something offering more flexibility. They do, usually the doses for those, besides HyQvia, usually the frequency is more often compared to the IV IG products. So that's something patients kind of have to consider. For the IV IG products, they're maybe going in like once a month, but with sub-Q products, they're having to infuse those like weekly or bi-weekly. But, for some patients, the at-home use could, make a big difference for them. And then the other thing with sub-Q products is they have a reputation of causing less systemic side effects. So if patients are tried on IV products and they try a couple IV products, if they can't tolerate some of the systemic effects, even by trying to modify the dose and things like that, then they may use a subcutaneous product, or they might want to try a subcutaneous product. So those are kind of the main things with differentiating those. I hope that kind of helps.
That's very helpful. Thank you.
Brian, correct me if I'm wrong, but I believe our original intent in 2015 was to provide at least one IV and one sub-Q product because of access to facility and the ability to possibly self-administrate the dosing and patient preference.
It wasn't explicitly stated, but that may have been an underlying intent. Our current PDL options do include IV and sub-Q options. If we wanted to formalize that in a motion, I'd be fine with that.
Is the current language on any of the handouts?
It's not. I could paste it into the chat if that would be helpful.
What, and I may have missed this, but what was the significance of the low IgA product?
So that that stems from, like, it's very rare, but some people can have IgA antibodies, and they, as far as I understand, they typically don't pre-test to see if someone has an existing antibody. But so there are all products, even the low IgA products, have a contraindication for patients that have antibodies. But in clinical practice, there's a way to get around that. They can either use a sub-Q product to, I guess there's different dosing strategies where they can actually have someone with an IgA antibody tolerate these products. So it doesn't necessarily prohibit their use completely. But anyway, the low IgA products will be a go-to for the very rare case that someone does have an IgA antibody. And it's kind of, it's very unclear as far as like at what level they'll tolerate IgA, because all products do have, you know, some IgA content, and it's unknown as far as like what the threshold is to which they will not react. So.
Okay, thank you. Does everyone feel, I mean, it kind of seems like that might be something that could be taken out then of the motion. And then we could insert the sub-Q and the IM kind of as being, you know, having at least one option. But that would be tough for FDA approved indications. So that may not be what we want to do.
Well, based on table 2, it looks like there's just 2 conditions that have both the primary immunodeficiency and the chronic inflammatory demyelinating polyneuropathy that have subcutaneous formulations available that are indicated. I just wanted to ensure that, you know, based on circumstance and access, that and, you know, judgment, that those would be available as well. But being that I didn't have as much clinical experience, I wanted to just kind of solicit any other input on that idea of whether it would be worth requiring a sub-Q formulation being available for those 2 indications. Does anyone have any thoughts about that?
So not having it on the preferred list is not going to necessarily stop. I mean, it'll have a prior authorization, right? So then they could still get the product if needed. So it's just whether we want to start in a certain place. Is that kind of what I'm understanding, Brian?
Correct.
All right. So it may not be necessary to really necessarily call that out.
Well, it seems like to me I think we all seem to be on the same page with continuing our current status of these, you know, not really adjusting the language, except for the IgA portion of the current recommendation. So I would make a motion to continue that immunoglobulins. Sorry, go ahead, Brian, if you have something to say.
No, I'm listening. I'm fine.
Oh, okay, sorry. So yeah, I would say we should make a motion to continue having these immune globulin agents on the PDL and require that at least one agent be preferred for each condition for which there's an FDA indication.
I'll second.
All in favor?
Aye.
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 And any opposed? Great. And do any abstain from that? I guess no. Oh, perfect. Cole's there too. So it looks like that's kind of everything we needed to go through with the immune globulins. Anything else with that you wanna go over, Brian?
No, I don't think so.
All right. Well, looks like it's pretty short and sweet then today. So it looks like our next meeting is going to be in February, on February 18th, and we're going to review the continuous blood glucose monitoring. And that should be very interesting. There's a lot of new things in that realm these days. So with that, I'll go ahead and motion to adjourn then.
I'll second.
And all in favor?
Aye.
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 All right. And any opposed?
Happy holidays, everyone.
Thank you very much.
Thanks, you too.
Bye-bye.
All right, guys. Have a good one.
Thank you.